ठीक है. So our first case is this. What are the symptoms in this case?
Redness.
Redness.
Age.
Age, that's good.
Blurring of vision, pain.
Blurring and of vision and pain. ठीक है.
And unilateral.
It's unilateral. That's good. So redness and pain. What are the differentials that come in your mind when these two symptoms are discussed? Pain and redness, along with blurring of vision.
Acute congestive glaucoma.
That's good. Number one,
Yeah.
acute congestive glaucoma. Other than that,
Uveitis.
uveitis, that's good. Number two, we have uveitis. Other than that,
Keratitis.
keratitis, that's good. Number three, we have keratitis. It can also present with blurring of vision, redness, and pain.
Blurring हो सकता है.
Other than that, what else? What else comes in your mind when the symptoms of redness and pain and blurring of vision they're presented? What else? What else? सोचो सोचो, इतना बड़ा इतनी बड़ी आई है. There has to be something else. जो आपने पढ़ी है पहले भी एटलीस्ट. जो वर्ड्स में आई उन्होंने तो पढ़ी है. क्या ये सिम्टम्स कंजंक्टिवाइटिस के नहीं है? Can these symptoms be
blurring
of
नहीं
conjunctivitis?
होगी.
पेन तो होता है. ब्लरिंग.
ब्लरिंग ऑफ विजन तो नहीं होगी.
Blurring of vision क्यों नहीं होगी कंजंक्टिवाइटिस में? When there is mucopurulent discharge in the whole conjunctiva, will it not disturb vision?
Okay.
Yeah, in acute blennorrhea, which is mucopurulent, is acute purulent conjunctivitis due to Neisseria gonorrhea, there is so much discharge then the person is not able to see. There is blurring of vision. Similarly, in cases of conjunctival discharge, such as in endophthalmitis or orbital cellulitis even, they can be red, painful, blurring of vision. Okay? So these differentials आपको हमेशा याद रहने चाहिए. So this is our case. A 38-year-old man presents with redness, blurring of vision, and pain in his left eye. This is the examination of this patient. On examination, what do you see?
Conjunctival redness.
Conjunctival redness, that is
congestion.
good. What type of conjunctival redness or congestion?
Around the cornea.
Around the cornea. What it is called?
Circumcorneal.
Circumciliary, circumcorneal, ciliary congestion. That is good. That is a good pick. That is one of our positive findings. What else?
The pupil is dilated and irregular.
Irregular towards which side? If this is the nasal side and this is the temporal side, on which side is the pupil irregular?
Nasal side.
On the nasal side. So we can see an irregularity in the pupil on the nasal side. So these are two of our main symptoms, signs in this case. Now, based on these symptoms and this examination, what is your, okay, all right, there's one more examination. This was a general stratum examination. When you use a slit lamp, okay, and use indirect illumination, from side, let's say 45 degrees. This is what you see. What are your findings in this examination? Keratic precipitates. All right. What kind of keratic precipitates? Keratic precipitates कितने types होती हैं?
फाइन होता है और
ग्रीजी होते हैं.
Greasy होते हैं. Excellent. So do these appear fine or do these appear greasy?
Greasy.
These appear greasy. Now these greasy keratic precipitates are called classically mutton fat KPs. And they are a symptom of sign of They are a sign of anterior uveitis. Yes, KPs are a sign of yes. The KPs are a sign of uveitis, anterior uveitis or iritis. But mutton fat KPs, they are classically a sign of granulomatous uveitis. Okay?
and chronic.
In granulomatous uveitis, it is due to direct infection by an organism. ठीक है, ये आपने बात याद रखनी है. जब हम ऊपर मैं आपसे डिस्कस करना चाह रहा था ना यहाँ पे इनके साइंस और सिम्टम्स का क्या फर्क होता है. Granulomatous, it has nodules. Nodules की I couldn't find a good picture. Parsons में है, but it's of low resolution. आप पढ़ लेना. And there are nodules on the iris. And secondly, there are greasy, large keratic precipitates, which are classically called mutton fat keratic precipitates, KPs. Now, granulomatous uveitis, it is due to direct infection by an exogenous organism, while non-granulomatous, they can be either allergic or immune-mediated. ये एक छोटी सी बात थी. अच्छा, there is also one thing more in this picture, in this examination, related to the KPs. What is that?
लोकेशन उनकी
Location.
ठीक है. What about the location?
Lower part of the cornea.
Lower part of the cornea. That is a very good pick. Okay, so keratic precipitates in case of uveitis, you will see that they are distributed according to the gravity, more in the lower part and in a triangular form. Okay, this is, I think, called arch triangle. I have to confirm. Okay, लेकिन ये आपने चीज याद रखनी है. Yes, this is called the arch triangle. This is a triangular patch of distribution जहाँ पे KPs सबसे ज़्यादा और सबसे पहले मिलेंगे आपको. Whenever you're examining a patient of uveitis. So this triangle, it goes like this. It's more or less like this.
Can you spell this triangle?
Okay, this is triangle. This is arch triangle.
ठीक है.
This is arch triangle. This specific distribution of keratic precipitates in the inferior part of the anterior chamber. This is where you will find keratic precipitates. Now, based on this findings in this picture and on this finding, what is your diagnosis? What is your provisional diagnosis?
Chronic या granulomatous anterior uveitis.
Anterior uveitis. ठीक है, anterior uveitis. How will you investigate this patient?
आपने जो टेबल कहा था कि हम याद करें,
बिल्कुल पढ़ा है किसी ने?
उसमें दो, हाँ मैंने पढ़ा था, उसमें दो टाइप्स लिखी हुई थी, एक हेट्रोक्रोमिक और उसके लिए हमने गोनियोस्कोपी करनी थी.
ठीक है, आपने टेबल का एक पार्ट बता रही हो आप. उस टेबल ने बेसिकली जो गाइड में दिया हुआ है उसमें क्लासिफिकेशन के लिहाज से इन्वेस्टिगेशन दी हुई है. If anterior है तो आपने क्या investigations करनी है, if it's posterior, if it's choroiditis, वो चीज़ें आपने याद रखनी है. बिल्कुल. However, you have to remember one thing, that based on a simple slit lamp examination, if you do not see the retina, you cannot say whether this is acute iritis, anterior iritis alone. इसके साथ posterior component भी है. because there is a thing called spillover uveitis. Okay? What is spillover uveitis? It means that whenever the posterior part of the uvea is inflamed, that inflammation, it spreads towards the anterior parts. That originally, if there is a pars planitis or a choroiditis, it can spread to involve the ciliary body or the iritis, and it can also present with a hypopyon and keratic precipitates. Which means that whenever you are investigating a case of uveitis, and these are the only symptoms, you have to do a lot of investigations. What are those investigations? Number one,
CBC,
CBC. Number two,
TLC, DLC count.
TLC and TLC. Will that not be included in the CBC?
Yeah, ठीक है.
Serology.
TLC/TLC. मैं आपसे पूछूंगा अभी कि why are we doing these? Serology for what?
ऑर्गेनिज्म का मतलब अगर किसी ऑर्गेनिज्म ने इन्फेक्ट किया है तो
In which organism?
बैक्टीरिया.
Which bacteria?
TB, tuberculosis.
ठीक है. So serology for TB. When we do serology for TB, what do we check? We'll write the specific test down. All right. When we're doing for TB, we'll do IGRA. Another thing. TB को हम अलग लिखेंगे. We do IGRA. We do this test. Spelling जिसके हमेशा भूल जाते हैं क्या होते हैं. And secondly, we will do a CXR. Serology हम किस disease के लिए करेंगे?
Syphilis, toxoplasma.
Syphilis and toxo. That is good. Toxo के लिए we do IgGs, IgMs, and for syphilis the test is called
FTABs.
PDR.
FTA, AABS.
PDRL.
Fluorescent tapenemal antibodies. We do venereal disease research laboratory test. We do RPR, rapid protein reagent test. Okay? This is good. This is the serology. What else? Also देख के बता दो.
X-ray of the joints.
X-ray of the joints. Which joints?
Sacroiliac joint.
Sacroiliac joints. Why?
For ankylosing spondylitis.
What is ankylosing spondylitis? Okay, it is a seronegative spondyloarthropathy. जो last time मैंने बताया था, it affects the axial skeleton. So we will do extra sacroiliac joints and extra spine. Okay, what else will we do? What else?
Yes, sir.
ESR, why?
Chronic inflammation.
ESR is a marker for inflammation. That is correct. ESR जब भी raised होगा, which means अगर आपको second year की थोड़ी बहुत याद हो physiology, it's enraged inflammation in which fibrinogen and other reactions of inflammation increase. Exactly. Someone said autoimmune panel. Yes. Autoimmune panel में हम क्या करेंगे? ANCA करेंगे. Why will we do ANCA?
ANCA नहीं नहीं करेंगे.
ANCA भी करेंगे. चलो ANA भी करेंगे.
ANCA lupus के लिए होती है ना?
Not for lupus. ANCA is for किसने कमेंट किया था vascular diseases के बारे में?
Vascular के लिए होता है हाँ. Vaginers or
disease. Yes, it is for There are two types of ANCA, P ANCA and C ANCA.
And
C
C.
anchor.
So when we're doing C ANCA, we're doing this for vaginous granulomatosis. All right. Vaginous ANA for SLE, lupus. What else will we do? Autoimmune panel हमारा हो गया. और बताओ.
C reactive protein for inflammation.
चलो, we did ESR. We'll also do CRP. Or
Angiotensin converting enzyme.
AS levels and CXR4
Sarcoidosis.
Sarcoidosis.
sarcoidosis. ठीक है. What else? और बताओ और कौन से टेस्ट रह गए हैं? देखो सारे टेस्ट हैं. It includes everything. Serology, CBC, serology, X-rays, autoimmune panel. और हम क्या चेक करेंगे? Will we check any metabolite?
Serum glucose level.
Serum glucose
sugar
level. Yes, serum glucose. That is good. What else will we check in the serum?
Uric acid.
Uric
Uric
acid.
acid for gout. What else will we check? अब एक examination, एक urine analysis. What will we do urine analysis for?
WBCs.
WBC.
Why WBCs?
Infection के case में.
सही बात है. WBCs will be positive in this infection. ठीक है, for pus cells. चलो इसको हम डिस्कस करते हैं. और बताओ. सारे हो गए हैं.
Stool examination.
Stool examination. Stool examination. Why will we do stool examination?
Toxoplasma कोई parasite हो तो.
हाँ, parasitic.
Yes, parasites which reside in the colon or the gut or the GIT. Stool examination.
तो फिर तो IgE और eosinophils भी करेंगे.
बिल्कुल करेंगे. Right, stool examination for ova and parasites, ONP. This is why we will do the TLC. TLC के अंदर we will check the eosinophils. More or less ये सारी चीजें हमने cover कर ली. We know that we will do CBC to check whether there's an inflammatory cause, and DLC if there's eosinophils raised, we can say we can suspect or we can prove that the cause is parasitic in nature, cause of uveitis. Serology for toxo, which is a parasite, VDRL and RPR for syphilis, TB, X-ray for ankylosing spondylitis, ESR and CRP for inflammation if cause is inflammatory. Autoimmune panel to rule out systemic diseases. Otherwise, ACE for psychosis, serum glucose for diabetes, uric acid for gout. Stool examination for OMP. Why will we do urine analysis for pus? uveitis में urine analysis का क्या तुक है?
साथ किडनी को चेक कर रहे हैं कोई सिंड्रोमिक इन्वॉल्वमेंट.
Exactly, we're checking the kidney for a syndromic involvement. Which syndrome involves the urinary tract in the uvea?
Reader syndrome.
Reiter syndrome. That is Reiter's. I'm not sure उसकी क्या pronunciation है, but exactly that is what we are checking. This syndrome involves uveitis, urethritis, and arthritis. Uveitis, arthritis, and urethritis.
वैसे conjunctivitis नहीं होता?
uveitis भी होता है, conjunctivitis भी होता है, but जहाँ तक मुझे याद है, yes, conjunctivitis और uveitis दोनों हो सकते हैं इसमें, but the more common association is with uveitis. So this is why we are doing urinalysis. Okay, if a patient comes to you with pain in the joints, on eye examination there is uveitis, and on urinalysis there are pus cells. So this means that the person has Reiter syndrome or Reiter syndrome, whatever the pronunciation is, and that the most common cause of this syndrome is
We did an organism. याद नहीं आ रहा.
कौन सा organism है?
Chlamydia होता है.
Chlamydia. The chlamydia infection is one of the commonest causes of Reiter syndrome. So this is how you will investigate a patient of uveitis. These are your investigations. Okay? This is what you have seen. What can be the complications of uveitis before we move on to treatment?
Secondary cataract.
One moment, मैं लिखता जाऊँ साथ-साथ. Okay, so number one,
Glaucoma.
secondary cataract. Then you have glaucoma. Then we have
Synecdoche, posterior synecdoche.
synechia. What else?
Optic nerve damage.
Optic nerve damage. What else?
Choroiditis.
Choroiditis is a type of uveitis. So uveitis cannot be a complication of uveitis. Yes, choroiditis can be a sequela. Choroiditis can be a sequela. It's not an complication. It's a sequela. Sequelum. I think sequelum ही होता है. When we're talking about sequela.
Choroidal detachment हो सकता है.
Choroidal detachment. Now that is a complication. What else?
Opacities.
Opacity is all right. What else?
Staphyloma.
Loma. Okay. चलो लिख लेते हैं. और बताओ.
Macular edema.
Macular edema. What else?
Tithys bulbi. जिसमें वो आई स्मॉल हो जाती है.
ठीक है. और 10 हो गई हैं. One more. I need one more.
Vision loss.
Vision loss. Vision loss is a symptom. The complications we are discussing the diseases or the disease entities which can occur. Okay, just like glaucoma. Okay, glaucoma. The symptom of glaucoma is vision loss. The symptom of phthisis bulbi is vision loss. The symptom of macular edema is vision loss.
Okay.
You have done 10. I will tell the last one. Achha. So these are more or less the different complications which can occur in a patient of uveitis. Now, specifically when we're discussing anterior uveitis, we're keeping in mind anterior uveitis. What can be the complications? इनमें से कौन-कौन सी complications हो सकती हैं?
Cataract, glaucoma.
Glaucoma.
ठीक है, glaucoma हो सकता है और synecdoche
हो सकती है.
Synecdoche formation.
Tithys bulbi.
phthisis bulbi. अगर हम strictly anterior, yes, if we include cyclitis in an anterior uveitis, so yes, we can have phthisis bulbi. ठीक है? तो
What is phthisis bulbi?
ये मैं अभी आपको बताऊंगा. थोड़ी देर वेट करना पड़ेगा. So what complications do you think we can have in pars planitis?
Vitreous opacity.
Vitreous opacity, exactly. We can have vitreous
Macular
opacification.
edema.
We can have macular edema. What else can we have?
Retinal detachment.
Retinal detachment,
Alright.
exactly. retinal detachment. We can have retinal detachment. Choroidal detachment, retinal detachment are more, somewhat different things. What type of retinal detachment can we have? आपको पता है retinal detachment की types क्या होती हैं? नहीं पता. चलो ये क्वेश्चन आप लिख लो. तो ये कमेंट करना इस क्वेश्चन को अगली टाइम जब हम रेटिना डिस्कस करेंगे तब इसको हम डिस्कस कर लेंगे. अभी इसको फायदा नहीं. ठीक है. तो we said that vitreosupastities हो गई, retinal detachment, these are complications of intermediate or pars planitis. Posterior uveitis की क्या complications हो सकती हैं?
Optic nerve damage.
Optic nerve damage. Optic nerve damage glaucoma में होगा ना? तो yes, glaucoma can be a complication of posterior uveitis. What disc edema? Yes, papillitis हो सकता है if the inflammation spreads to the optic nerve. We can have retinal detachment. We can have choroidal detachment even. Okay. We can have a complicated cataract. Okay. So when we're talking about the complications of uveitis, we see that which of the uveitis is given. In this case, in our case, the diagnosis is also of anterior uveitis. So anterior uveitis, we can have a secondary cataract, we can have a glaucoma, we can have synechia, we can have phthisis bulbi even, or we can have even choroiditis. But vitreosupacification or retinal detachment and choroidal detachment, they are less common unless the posterior part of the uvea is secondarily involved. ठीक है, यानी कि इन्फेक्शन आगे है, अगर आगे से पीछे जाएगी, then we can have these other things. अब specifically due to anterior uveitis हमारे पास ये चीजें होंगी. चलो हम इनको एक एक बारी बारी डिस्कस कर लेते हैं. Secondary cataract, that is good. A complicated cataract due to inflammation बन सकता है. Glaucoma, glaucoma क्यों होगा इसमें? In uveitis.
जो एक्सिडेट है वो ब्लॉक कर देगा ट्रेबेकुलर मेशर.
नहीं, ब्लॉक हो जाएगा मेशर.
ठीक है. In glaucoma, number
एब्जॉर्प्शन नहीं हो रही होगी.
ठीक है, that is good. ठीक है. Blockage of
ट्रेबेकुलर मेशर.
blockage of tubercular muscle. That is one cause. What can be another cause of glaucoma in uveitis?
जो एक और भी तो रूट होता है एक्वस ह्यूमर की ड्रेनेज का.
होता है. It is not by the trabecular meshwork. It is through directly into the Kalan or Schlem. That is correct. Is that the main route of aqueous
No.
drainage? No. The main route is the trabecular network. And if that is blocked, we will have glaucoma. And the second is
एंगल ब्लॉकेट. synechia.
one said synechia. Yes, that is correct. Synechia. Now, this blockage of trabecular muscles, it is called trabeculitis. जगह जगह को मिलेगा trabeculitis. Inflammation of the trabecular network, or it can be the second name given to this is inflammatory glaucoma. Because they're inflammatory cells, and this glaucoma is due to inflammatory cells. Another name is hypertensive uveitis. This is all one thing, लेकिन उसके इतने मुख्तलिफ से नाम रखती हैं. ठीक है. Inflammatory cells in the trabecular meshwork, उसको trabeculitis कहते हैं. When we're thinking from a glaucoma point of view, we'll call that as inflammatory glaucoma. When we're thinking from a hypertensive, from a uveitis point of view, we will call it hypertensive uveitis. Why? Because intraocular pressure is being raised. And secondly, it is due to synechia. Now, synechia, there are of two types. Okay? One type, आप book में पढ़ोगे, one is called occlusio pupillae, and the second is called seclusio pupillae. What happens in one type is that the rim of the iris is attached to the anterior surface or the anterior capsule of the lens. That will cause ballooning out of the iris, and that will cause glaucoma because the aqueous flow from the posterior chamber to the anterior chamber is being impeded. Secondly, jiska कहनी है, this is the same thing. This is seclusive papilla. You can see in this picture that the posterior margins of the iris, they are attached to the lens, especially on this side. Okay, the pupillary margin is normal on this side. However, this is attached. So due to this attachment, the pupil, it becomes the pupil, not the pupil, the anterior chamber. The anterior chamber, which should be normally rounded, it becomes funnel shaped. There's a different concept. If this is the cornea and this is the iris over here, okay, and this is the lens. When this thing, अगर यहाँ पे synechia develop होंगे, this is called seclusio pupillae, and which means that the iris is going backwards. So जब iris backwards attach होगा, what will happen is that, let's suppose this is the iris which is being attached to the lens. So the anterior chamber, this is the anterior chamber. This anterior chamber, it becomes funnel shaped. And this is called, the pupil then is called a festooned pupil. ठीक है? Books में आपको जगह जगह लिखा मिलेगा a festooned pupil. This was a complication or complication. So secondly, in this picture, what else do you see?
Nodules.
Nodules. No, there are no nodules. इस पिक्चर में nodules नहीं है. Nodules margin पे होंगे और on the anterior surface, which looks more or less clear. What else do you see in this picture?
ऊपर सबसे ऊपर जो है white lines जो है.
These white lines, these are actually reflections of the eyelashes in the cornea, which we are seeing to the slit lamp.
Okay.
ठीक है? Similarly, this white light is a light जो light slit lamp examination पे light side से डालते हैं. This is that light.
Pupillary margin irregular है.
बिल्कुल irregular है. It's irregular on this side. I'm not sure it's the nasal side or which side, but it is irregular on this side because it attached posteriorly to the lens. And this side is normal. That is our posterior synecdoche. What else is abnormal in this picture?
ये hypopyon है नीचे थोड़ा सा.
Exactly. This is a hypopyon. What is hypopyon?
Exudate in the
Anterior chamber.
Okay. It is a sterile exudate consisting of inflammatory cells. This is a hypopyon. इस picture में hypopyon. तो ये हो गई. अच्छा, ये picture है. This is also a slit lamp examination. This briefly shows the mutton fat erectic precipitates. Mutton fat KPs. These are abnormally large. And when microscopy is performed, we can see that this is the cornea. This is the endothelial layer, and these are the mutton fat KPs which are adherent to the endothelium. Okay? So these were our complications. Optic nerve damage हम discuss करेंगे. We can say that this nerve damage is due to glaucoma or raised intraocular pressure or bouts of glaucoma. ठीक है? Just want to discuss that in inflammatory glaucoma or hypertensive uveitis, the glaucoma does not need to be common. Does not need to be present all the time. ऐसे हो सकता है कि when the inflammation is severe or when the person is not on his medication, not properly on medication, more inflammatory cells are released into the anterior chamber via the aqueous humor. More cells, they get trapped inside the trabecular nerve, and at that moment they can cause an increase in IOP, which can mimic glaucoma, acute congestive glaucoma. That's right. So choroiditis is a sequela, choroidal detachment, victus of pacification, staphyloma, macular edema, retinal detachment. Retinal detachment we will discuss when we will be discussing retina. Now the important thing over here is that you have to remember that whenever there is inflammation of the choroid, the retina will always be involved. Meaning that हमने discuss किया कि toxoplasmosis or syphilis or TB, when these infect the choroid, they can also infect the retina. ठीक है, तो that is why
Okay.
the infections of the choroid, they will have retinal symptoms. These infections will have symptoms such as कौन से retinal symptoms हैं? चलो छोड़ो, let's move on to the treatment of this case. ठीक है, क्योंकि treatment of uveitis, more or less all of the uveitis, anterior, posterior and intermediate uveitis, it's more or less the same. So what will be the treatment of this?
Steroids.
Okay, that's good. Steroids. What else?
Mediatrix.
Mediatrix. Which mediatrix?
Cyclopentolate.
That is good. Cyclopentolate. Give me another name. Atropine. That is good.
Atropine.
That is good. Steroids. Mediatrix. What else?
NSAIDs.
NSAIDs. That is good. NSAIDs for pain and NSAIDs to decrease the inflammation. What else will we do?
Antibiotics.
Antibiotics. Yes, if the cause is inflammatory, we will give antibiotics. What else do you think we should do?
Immunosuppressant.
Immunosuppressants. Immunosuppressants क्यों देंगे? कब देंगे?
Systemic disease हो साथ.
Exactly. Which systemic disease? Arthritis syndrome is a systemic disease.
जिससे ankylosing spondylitis या readers की अगर हमने बात किया.
Arthritis is, as now we can make it, arthritis is a systemic disease, but it is infectious in nature. The media, most probably that arthritis syndrome will also be treated. Okay? Immunosuppressants किस में देंगे?
Autoimmune.
Autoimmune में देंगे. We can give immunosuppressants in Wegener's, for example.
Wegener's.
SLE and Wegener's.
SLE and Wegener's, if those diseases are not being controlled by steroids. बिल्कुल, that is good. चलो ये हमने treatments हमने outline करी. What else do you think we should do? 1 मिनट रह गया, जल्दी से बताओ, फिर हम इसको conclude करें. नेक्स्ट वीडियो के अंदर एक और केस वो डिस्कस करके खत्म करते हैं.
Heat application.
Heat application, that's good. Resting with heat application. What else?
Antimetabolites.
Antimetabolites, they overlap with immunosuppressants. और बताओ. और क्लासेस सोचो. चलो मेडिकल ट्रीटमेंट, मेडिसिन, ड्रग्स के अलावा व्हाट डू यू थिंक वी शुड ट्रीट द कॉम्प्लिकेशंस एज वेल?
सर्जिकली आयरेक्टमी कर सकते हैं.
आयरेक्टमी करेंगे. आयरेक्टमी फॉर किसके लिए कहते हैं आयरेक्टमी? ग्लाउकोमा के लिए. सो फॉर ग्लाउकोमा वी विल डू आयरेक्टमी. दैट्स गुड. और क्या करेंगे?
कैटरैक्ट के लिए कर लेंगे सर्जरी.
Yes, exactly. कैटरैक्ट बन गया, we will do phacoemulsification. मैंने एक और बात की थी दरमियान में. Arthritis syndrome है, तो if we treat that syndrome, we can treat the disease. So we will treat the cause. If there is systemic